Thank you for your introduction. So in the following, I will talk about challenges of pediatric hydrocephalus. Yes, I am a mechanical engineer by training, and I was also challenged by Yehuda Soleman asking me why I am presenting this topic. So I do a lot of research on hydrocephalus and more on adult patients, but in collaboration with Dr. Gutzmann and Dr. Soleman, I want to work on pediatric hydrocephalus as well. And this collaboration also includes Dr. Chabang from the Edward Francis Small Teaching Hospital in the Gambia, and the veterinarian Dr. Marianne at the University Hospital, with whom we do all the investigation in vivo. So now, what are the challenges in the therapy of hydrocephalus? So depending on the income setting, so depending where you live, the therapy may be different because you don't have enough money to pay an expensive implant. And shunts that are mainly used to treat hydrocephalus is a technology that has been the same for the past 60 years and has not improved much. And I think a further challenge, it just came to my mind when you were talking, Thomas, is really that for children, it's even more difficult to convince companies that they should work on a device for children because there are less that can be used and sold. So this was always a problem when I was at conferences and tried to convince companies to have a collaboration with me. They said that's not of interest because we don't sell enough products. And this is what I said. So another challenge, definitely. Now, briefly about physiology. Now, I have to be careful about the colors because they look completely different on the screen here than for you at home. So the ventricles are shown here, yes, still in green on both sides. They're filled with cerebrospinal fluid that is produced in the choroid plexus, marked in red, and flows out of these ventricles into the subarachnoid space, which is marked in gray. Blowing up the ventricles a little more because they play an important role in hydrocephalus. So when there is, for instance, a blockage, we talk from non-communicating hydrocephalus, and the ventricles that are upstream, they do increase in size and push the brain away of the child. In these circumstances, children have an increased intracranial pressure, where in the communicating hydrocephalus, there's probably no blockage, but we don't really know because the etiology of non-communicating hydrocephalus is not really known. And what we know is that there is an imbalance in production and resorption of cerebral spinal fluid, and therefore there's also an increase in ventricular size and a decrease in brain parenchyma. But these children and also adults have a rather regular intracranial pressure. So for the children, there is one child with hydrocephalus with per 1,000 live births. And we expect that in developing countries, there are even more because of malnutrition, low birth weight, and elevated impact of neonatal infections. For instance, in sub-Saharan Africa, it is expected that there is, or it is estimated that about 100,000 children develop hydrocephalus by the age of 1. One other problem is that in such countries, there is only one neurosurgeon available for 5 million people, where in Europe, there is one neurosurgeon for 100,000 people. And you can imagine that is an issue as there's just no one there. And families also live very far away from the centers, which makes it even more difficult to treat them. In other words, we need a doable treatment that has a low complication rate and also less interventions needed. Now, how is hydrocephalus treated? Mainly by the placement of a ventriculoperitoneal shunt, which is marked in red and here pinkish. So we have one side of the catheter placed in the lateral ventricle, the shunt or the valve at ear level, and then the cerebral spinal fluid is drained down to the abdomen. And the valve that is placed and has not changed, so that's a one-way differential pressure valve that opens up when the pressure over the valve increases a certain preset value of this valve. And the surgeons need to decide preoperatively what shunts they want to implant. Some can actually be adjusted, but the child needs to see the doctor to get it adjusted if it is possible. And on the left-hand side, you see the child as such a shunt is implanted. And further therapy option, which is specifically interesting for developing countries, is endoscopic third ventriculostomy, which is here mainly used for non-communicating hydrocephalus, where they punch a hole in the third ventricle and then cerebral spinal fluid can drain out directly to the subarachnoid space. There is no additional implant needed. In addition, the choroid plexus will be cauterized. In other words, the production of CSF is reduced, which helps again to treat these patients. And it seems that they have a good outcome also if they have communicating hydrocephalus. But because these children, for instance, in developing countries have a need of a therapy, looks that it really does a good job. Now we want to come up with a more sophisticated solution, but how can we do it if we don't understand the system? And therefore, I have started my research 10 years ago by taking knowledge from literature, implementing it in mathematical models, modeling the dynamics from the arterial to the venous side, and also including the CSF space, using these models on an in vitro test bench, which allows to mimic a human being, here shown as an adult, it can as well be a child. And we can now also move this test up, so set up like as we also move around, so we can sit up or lie down. All this knowledge is taken mainly from in vivo trials, and without these we would not know, but from a healthy person we cannot investigate. So this is the tricky point about hydrocephalus, I guess, in comparison to cardiovascular, where we probably have more information. And so this has been my problem, trying to come up with a solution without knowing what is the best way to go. So in other words, from all these investigations, we want to come up with a better clinical solution for these children. And with this, I'd like to go a little bit down to my personal research on adults, where we have started investigating sheep, so adult sheep, and dynamics in different body compartments of a sheep to see how these interact. And we do that by placing several pressure sensors into the sheep. This is now acute. So we have 2 recordings of arterial pressures, 2 of venous. We have an intracranial pressure, intrathecal pressure, and 4 abdominal pressures. They have a high resolution, these data, and we can then see how they interact and how they communicate. And by that, we try to understand the system better. This is an example of results. So we see pressure in millimeters of mercury over time in minutes for 6 different sheep. And I'd like to go into 2, 3 specifically. So if you look at sheep B, we see in red blood pressure, in green is intracranial and intrathecal pressure, and in blue is here rather black, it's central venous pressure. What is of interest in sheep B, we have 6 consecutive boluses that were injected, so 2 milliliters of saline solution. And they were injected to the intrathecal part. And for sheep B, we can see that the pressure increase in the intracranium is kind of immediate and at the same height as for the intrathecal side. So we can see that there is a communication between these two compartments, which we would expect. Now for sheep A, there is hardly any communication. We have the bolus injections, but we see that the intracranium hardly reacts. There is just a little peaks. So this is now the bottom line in sheep A, dark green, where we can see there's a small influence, but not much for that sheep. And for sheep F, so bottom right, there we see besides good communication in the from the intrathecal to the intracranium, there is also a reaction in the arterial side. So this is an observation, and we need to come up with what they mean. Furthermore, we investigate the same pressures in a chronic study. So this sheep has sensors implanted, and to get the sheep doing a bit what we do, we let it walk over a bridge that she varies her position, and also sit her in a chair that to mimic our upright position. And this is not so unusual for a sheep, because when they get shaved, they are also set into such a chair. So that's not so critical for the sheep. And here we can see such a sensor in place. So that's a telemetric sensor that measures, in this case, the 4 abdominal pressures, and that's then telemetrically submitted, and we can record it. Of course, the tricky point is how do we correlate the posture to the data that we measure. And so we have developed an automatic algorithm that identifies the posture of the animal that is here marked in pink. And furthermore, to observe the gait of the animal, we also put such IMUs, so inertial measurement units, on the sheep, that we can see the gait of the healthy sheep for later on comparing it to a diseased sheep. Because as we know, hydrocephalus has a specific gait pattern, and we want to observe if when we introduce hydrocephalus, if the sheep really has hydrocephalus. So this is one of the options that we have. And here we see Anthony that trains the sheep and how she walks over the bridge. And we can also see how these data points are automatically identified. This is a bit harder here, but still, so the pink line and the dots where we then see how the position of the sheep is. Another example in the chair. So at the top, the same measurements as introduced before, arterial, intrathecal, intracranial, and central venous. And at the bottom, there are the 4 abdominal pressures. Not so much important of the mean pressure overall, but I think it's more important to observe how the pressures change due to the sitting position of the animal. So for instance, the light green at the top, so this is the intrathecal pressure, increases a lot during this upright position. And as soon as the sheep gets released, it decreases again. And I think this is also what we expected, because we have a hydrostatic pressure acting on top. And when we or the sheep is in upright position, the pressure in the lumbar part increases. We want to continue our investigation with pathologic sheep. And this is now more demanding, because there is no hydrocephalus model, or hardly any hydrocephalus model existing that mimics communicating hydrocephalus, because most of the models that are available is done with kaolin. So that is, then you block the system, you cannot really control it. It's just, yeah, it's done and it's happening. So for us, we want to introduce a model that we can control. And Di Rocco et al., they have actually come up with a model in the 70s that induces hydrocephalus. So when we look at image A, we can see a lamb brain, which is healthy. And then for B, we can see after his actuation that there was actually a dilation of the ventricles. And that shows a kind of hydrocephalus appearance as we want it. And the sketch shows how we actually do it. So we have a voice coil that actuates balloons synchronized to the cardiac cycle, that we have every pulse that we have. We also have a pulse in the intracranium. So there is a balloon placed in one of the lateral ventricles, and then we infuse and deflate according to the cardiac cycle. We also measure pressure, volume of the ventricle, and flow. So here we are at the beginning, and these are only preliminary results. At the top, you can see how such a pressure, intracranial pressure looks like. So we are already a little increased at 26 millimeter of mercury, but the pulse is rather low. And in the middle, when the actuation is in place, we can see that the pulse pressure is much increased. And that's exactly what we want. But what we've not achieved yet is that we go for 24 hours, because that's what Rocco did. It really needs a long time to have these pulse pressures at such an amplitude in place, and then we will see what we get. And then the bottom results show what it looks like after we stop the actuation. And again, the pulse pressure decreased, but the mean ICP increased a little, but the aim would be to have the mean of the ICP in physiologic level, but only an increase in the pulse amplitude. So we have now already quite many results, but there's still much to go. But what do we want in the end? We want to improve the treatment. How can we improve it when we do not have the knowledge? So, but that's what we hope to get by these investigations that we do in sheep. And for instance, but we foresee for the shunt treatments to improve, so far they're passive valves. So they just open when the pressure is at a certain level. But what we want is that they adapt to the patient needs. So according to what I haven't mentioned before, I mean, shunts, they may overdrain because of a posture change when you're in upright position. They have certain units that they don't do it, but still it's not controlled actively. And that's what we, by our investigation, want to achieve. And in the end, that they will be controlled in an active manner, that also patients as well as clinicians can interact, and maybe that we even get a readout like to a smartphone where we can see what pressures do we have, what is actually happening. So this is one side, which is probably more of interest for developed countries, because these shunts will be expensive and will be even more difficult to be available in developing countries. The other approach that I introduced before, so this endoscopic third ventriculostomy and combined with the choroid plexus cauterization, is more used, and it's probably the better treatment for these countries where there is not much available and where we need less complications and be sure that these children still have a good treatment. But these treatments are done. They're not, I mean, there's a lot of studies done, but we do not understand how, for instance, an isolated ETV works, or how long do the openings remain? Is there still flow through the aqueduct? And this is what we want to investigate in a further study in lambs, where we can quantify this therapy in an isolated manner, as well as the cauterization of the choroid plexus. How much is needed to be taken off? In the end, we need CSF. We reduce it because it's needed for these patients, but maybe we can also do with less, but we don't know. And then in the end, the combination of the two therapies, which will then help to derive digital knowledge base for more informed clinical decision-making with continuous multilateral knowledge transfer. So this is the goal. And we try to do it by, as I mentioned, in LAMP, according to the actuation system that we have in mind, because we think we can control hydrocephalus in such a manner and also be communicating or non-communicating. We even have the idea that we want to introduce the hydrocephalus in the non-communicating case with such balloons in place instead of cowling. Yeah, with this, I come to the end of my presentation, and we do hope that with all our investigations that we do, that we can really come up with better solutions, particularly for children. I'm happy to answer any questions.